Thank you very much, Dr. Shah. Good afternoon, ladies and gentlemen. I am going to comment on selected aspects of therapy of patients with hypertension who happen to have diabetes and patients who have diabetes who ultimately develop hypertension. Multiple complications can occur in patients with hypertension and diabetes, and with effective therapeutic intervention we can reduce the disease burden. And let's talk about some of the options that are available and which should be applied to the ultimate benefit of the patient. This morning I have shown this illustration that cardiovascular complications of diabetes, particularly in patients with hypertension, are multifold, are manifold, are deep, are large and long. So very extensive implications of patients who is burdened with hypertension and diabetes. This also I have shown earlier to drive a point: when you combine high blood pressure and diabetes, there is a tremendous increase in the risk of stroke, and this is what is known as a multiplier effect, where one thing multiplies the other, compounding effect, where one condition ignites the other, and both of them burn the health of the patient. And that is very important for us to know the combination of hypertension and diabetes is very, very deadly. I also have shown earlier that one of the markers of endothelial function or dysfunction is proteinuria. Whenever there is excessive proteinuria, whether you want to call it micro or macro, it doesn't matter, it is a reflection of endothelial dysfunction. When you use antihypertensive drugs that have been shown to reduce proteinuria, you are indirectly implying that we are using antihypertensive drugs that improve endothelial function. Actually, antihypertensive drugs by themselves may not reduce proteinuria unless they improve the vascular health. So there is no antiproteinuric antihypertensive drug, but there is vasculoprotective antihypertensive drug, and vascular protection is mediated and governed by the protection of endothelial function. And all of you are quite aware that whenever there is transition from normal protein excretion to small amounts and large amounts, there is increase in cardiovascular risk, and this is all probably due to vascular dysfunction. Because protein comes in the urine, it does not have much respect, but actually proteinuria is a marker of cardiovascular dysfunction. Now, Dr. Shah has mentioned earlier about the therapeutic goals for treating patients with hypertension and diabetes, and this is an illustrative slide showing that the patients who have high levels of blood pressure and diabetes, they have a rapid decline in renal function, but if you restore the blood pressure towards the proximity of 130, you stabilize renal function. Let me make one comment on very simple comment on what the goal blood pressure should be in a patient who has got concomitant diabetes and hypertension, which has not been covered in any guidelines. This was a paper that was published 3 months back in 4 lakh patients, 400,000 patients with hypertension and concomitant conditions being followed. The best outcome was in patients who achieved a systolic blood pressure of 130 and a diastolic of 79. So in my opinion, Mr. Chairman, ladies and gentlemen, the goal blood pressure in a diabetic hypertensive should be 130 or 80, and if you achieve a lower blood pressure, there does not appear to be any harm done. First of all, you should not worry about hypotension in patients with hypertension. The problem in patients with hypertension is high blood pressure, not low blood pressure. So don't worry about excessive lowering of the blood pressure, which is unusual. But I think on the basis of this landmark study that I have quoted, I think one should continue to be very aggressive in treating hypertension, because very rarely you cause drug-induced hypotension. And I also mentioned to you this morning that patients who have diabetes, are at high risk for cardiovascular complications. And this is a study which was done many years ago in the elderly patients, diabetics and non-diabetic patients. Even when you treat diabetes in patients with hypertension, they are at a higher risk than a non-diabetic patient who is not receiving antihypertensive drugs. Very, very important finding that should be very alarming. Hypertension optimal treatment trial was mentioned by Dr. Singh earlier on in the context of aspirin use. And this is probably one of the first trials to demonstrate that you can reduce the major cardiovascular events in a diabetic hypertensive by reducing the blood pressure in the proximity of 75 to 80. Nobody is asking you to reduce the blood pressure to diastolic 60, 50. Nobody is asking you to reduce systolic to 110, 100. So how does hypertension come at all? It is out of the picture. We are only asking people to reach the goal. For example, glycated hemoglobin, when you're treating diabetes, is anybody asking you to reduce glycated hemoglobin to 2, 3, 3.1? Why do you worry about that? Treat to the goal that is good enough for most patients with hypertension. And now this is a study, European study on hypertension, once again showing that once you treat patients who have diabetes and hypertension, the benefits are really, really remarkable, and one should not neglect this combination. I have a different view of the ACCORD study, which has been repeated, recited so many times, that whether the blood pressure should be aggressive, low or super low. You see here there is a blood pressure, let us round it off, 130 systolic, 120 systolic, and there was a tendency for reduction in stroke. There was no difference in terms of cardiovascular outcomes, myocardial infarction, revascularization, but there is a tendency for reduction in stroke. So whenever there is a tendency for reduction in stroke, in my view, it is very important finding, because stroke is one of the most devastating complications of hypertension. Stroke is one of the most embarrassing complications of hypertension, because not only it affects the individual, but it affects the family, the attendants, the community, the disability, the rehabilitation, work absenteeism, loss of productivity. So when you reduce the tendency to the stroke, it is very, very important. This is a study that I mentioned to you earlier, published after all the guidelines, based upon nearly 4 lakh patients. You will notice that the ideal blood pressure should be in these patients 130 to 139, diastolic in the proximity of 80. Of course, when you reduce the systolic blood pressure to less than 110 or diastolic less than 50, they have poor prognosis. But nobody is asking you to do it. Nobody is asking you to reduce diastolic to 50. The reason why people have diastolic 50 is they have cardiac dysfunction. They have underlying cardiac disease. They are unable to generate high levels of blood pressure. That's what it means. Now, let me talk for a few minutes on therapeutic choices in management of a diabetic hypertensive. One of the recommended class of drugs would be the drugs that block renin-angiotensin system. Whether you want to call them ACE inhibitor or angiotensin receptor blockers, it does not matter at this time. But this is a kidney on your left side, normal kidney, whereas on the right side is the pathological specimen from a diabetic kidney. You will notice diabetic kidney is thickly populated with angiotensin converting enzyme and thickly innervated by angiotensin. So there is greater density of the renin-angiotensin system in the diabetic kidney, and renin-angiotensin system in the diabetic kidney is not an innocent bystander, but it causes considerable harm. So the drugs that block renin-angiotensin system actually have important effects in the kidney in blocking the effect of the renin-angiotensin system on the kidney function. Now you can block renin-angiotensin system either at the ACE level or the angiotensin receptor level. Blocking the renin-angiotensin system directly, direct renin inhibitor, does not offer any advantage over ACE inhibition or ARB. This is the first study in human literature showing that when you give a renin-angiotensin system blocker, ACE inhibitor, at that time captopril, in patients who have diabetic renal disease, the usage of an ACE inhibitor decreased the progression of renal disease. It does not prevent it, but the progression of renal disease was inhibited by an ACE inhibitor. First time demonstrated that ACE inhibition might be useful in preventing the progression of diabetic renal disease. And subsequently, there was a lot of interest on ACE inhibition and protective on the kidney. And this is actually published but not shown here. This is a study that we looked at the renal blood flow in diabetic hypertensives receiving an ACE inhibitor, and we noted despite a fall in blood pressure, the renal function was well preserved, suggesting you might drop the systemic blood pressure, but you don't drop the renal blood flow. It is auto-regulated, and that is the importance of renin-angiotensin system. Now, one of the challenges in treating diabetic hypertensive patient is when you give an ACE inhibitor or when you give an ARB, sometimes there is a modest rise in blood urea nitrogen and creatinine. For example, if the creatinine was 1.2, it might become 1.4. If the blood urea nitrogen was 29, it might become 34. So there could be a transient loss of renal function when you give a RAS blocker. You see, there is a fall in blood pressure. When there is a fall in blood pressure, there is also a reduction in GFR. But when there is reduction in GFR, you should continue the treatment. When you continue the treatment, there is a recovery of normal renal function. So despite a reduction in blood pressure, there is a recovery of renal function. So you have to be patient. You have to withstand the situation. I'm not saying if somebody's creatinine becomes 5.4, you should observe. But whenever there is a 30% increase in blood urea, nitrogen and creatinine during RAS blockade, just be patient because the renal function improves despite a reduction in blood pressure. So RAS blockade, when it causes a little bit of azotemia, it could be used as a marker that RAS blockade is working. You continue the treatment. For example, when you give a beta blocker, what happens to the heart rate? It goes down. You continue the treatment, right? So RAS blockade is like a pacemaker of the kidney, where despite the RAS blocker, the renal function improves over a period of time. Now, one of the drugs that was shown to have renal protection after captopril is well known to you, ramipril. In the HOPE study, a subpopulation who has diabetes have been shown to have a reduced risk of myocardial infarction, stroke and cardiovascular death. So one more study suggesting that chronic ACE inhibition appears to be protective cardiovascular-wise in diabetic patients. Now, angiotensin receptor blockers. This is not a very fair study called LIFE study, looking at the comparison between a beta blocker and an angiotensin receptor blocker. Angiotensin receptor blocker was superior to a beta blocking drug. But what was not clear in the study was beta blocker harmful or was ARB beneficial? That is a dilemma that was not answered by the study. There are a number of angiotensin receptor blockers that are available now in our country. One angiotensin receptor blocker that appears to have important metabolic effects is telmisartan. Telmisartan is also known as metabolic sartan, or it is also known as cardiorenal sartan. The reason is because of its partial effects on PPAR gamma, it appears to improve insulin sensitivity and decrease insulin resistance, and also improve the lipids. This is a study comparing two angiotensin receptor blockers, valsartan, which is not widely used in our country, and telmisartan. You will notice the parameters of glucose metabolism improved with telmisartan, parameters of lipid metabolism improved with telmisartan, and vascular inflammation went down with telmisartan, whereas valsartan had no such effect. So the conclusion of this paper was between telmisartan and other ARBs, because telmisartan is bestowed with the so-called adjunctive property of PPAR gamma, it appears to have favorable metabolic effects that could be of importance in people who have multiple cardiovascular risk factors such as diabetes, hyperlipidemia. Very important distinction amongst the ARBs. And this is a small study, not an outcome study, looking at insulin resistance before treatment with so-called cardiometabolic sartan, telmisartan, and afterwards. There appears to be an improvement in insulin sensitivity because of its partial PPAR gamma effect. Angiotensin receptor blockers in patients who have diabetes and chronic kidney disease, they tend to be pretty safe as long as you keep an eye on potassium. All degrees of renal impairment have been shown to benefit from sustained use in this particular study with telmisartan, but ARBs are very good. Just keep an eye on potassium. Now, this is a study called AMADAV, which compared losartan with telmisartan on cardiovascular endpoints. And again, in this particular study, telmisartan was slightly superior to losartan. Whether this is due to the duration of action, which is long and sustained, or whether due to metabolic effects is not known. But nevertheless, very interesting. Only one of the few studies which has compared two sartans. This is a study comparing diuretic hydrochlorothiazide with angiotensin receptor blocker in patients who have diabetes. Both of them reduce the blood pressure. With hydrochlorothiazide, there is a slight increase in glucose, new onset diabetes. With ARBs, there is no new onset diabetes. But despite an increase in glucose, the therapeutic benefits appear to be very, very similar. Now, one should always use optimal dose of a drug. When I say optimal, I am not saying high dose or toxic dose. This is a study called IRMA-2, which was done in patients who had diabetes and proteinuria using an angiotensin receptor blocker, irbesartan, which is not very popular in India. But you will notice here, when irbesartan was given at 300 milligram, there was a greater reduction in renal events compared to 150 milligram. So when you use a renoprotective drug, you must always try to use optimal drug, optimal dosage based upon studies like this, how a higher dosage appears to be more protective than a dose that is just enough to reduce the blood pressure. And this is one more way of looking at the previous study. Normalization of urine albumin excretion rate was highest with 300 milligram, which is an optimal dose, compared to 150. Now, finally, comments on beta blockers in patients who have diabetes and hypertension. It is still somewhat controversial, but beta blockers have been shown to be very protective in diabetic patients who have coronary artery disease. This was a study that was actually being done with fenofibrates, but some patients received beta blockers and some did not receive beta blockers. Patients who received beta blocker had a better survival than patients who did not receive any beta blocker. So the conclusion of this study was a diabetic patient with coronary artery disease is better off being on a beta blocker rather than not being on a beta blocker. But this enthusiasm was somewhat tempered because the beta blocker controversy has set in up subsequently. Now, which beta blocker can you use? Two beta blockers which appear to have good effects on insulin sensitivity are so-called vasodilating beta blockers. One example would be carvedilol, which is not very popular for hypertension in India. But you will notice when carvedilol was used, not only the blood pressure came down, but there was an improvement in glycated hemoglobin and glucose. Similarly, when you compare nebivolol, which is a vasodilating beta blocker, with atenolol, the insulin resistance improved significantly with nebivolol compared to atenolol. So these two drugs, vasodilating beta blockers, appear to be very good choices in patients who have diabetes and hypertension due to these metabolic effects. And lastly, a comment about whether one should use diuretics in patients who have diabetes and hypertension. And this is an all-hat study where chlorothalidone, amlodipine and lisinopril were used. Chlorothalidone had a chance of causing more diabetes than other drugs. But when you look at cardiovascular outcomes, they were very similar. Despite the new onset diabetes with chlorothalidone, the overall cardiovascular benefits were very, very similar. So the take-home message is, if patients require a diuretic and has diabetes and hypertension, do not hesitate to use them, because despite alterations in glucose metabolism, the ultimate outcome appears to be very similar. So Mr. Chairman, ladies and gentlemen, in conclusion then, diabetes and hypertension are core culprits in robbing a patient of his health. Health is treasure, and the treasure is robbed when you have both diabetes and hypertension. Both diabetes and hypertension can increase cardiovascular disease, chronic kidney disease, cerebrovascular disease, and don't forget peripheral arterial disease. Antihypertensive drugs, when you use, keep an eye on volume depletion. I mentioned to you about renal function, cardiovascular function. When you use ARBs or ACE inhibitors in patients who have diabetes and chronic kidney disease, keep an eye on potassium. Make sure that it does not go beyond 5.5. Around 5.2, 5.3, I tend to be very, very careful. And when you use multiple drugs to reduce the blood pressure, which is okay, but once in a while, please check the patient's postural BP, because some of these patients might have autonomic neuropathy, and you might precipitate and aggravate postural hypotension as a result of treating supine or sitting high blood pressure. So, Mr. Chairman, ladies and gentlemen, hypertension and diabetes are only risk factors. When the risk factors are there, when they are stable, the blood vessel is healthy, normal circulation. But when you don't treat them properly, they develop hypertensive disease or diabetic disease where there is atherosclerosis and occlusion. When you don't treat hypertensive disease, diabetic vascular disease aggressively, the patient becomes disabled with occlusion, myocardial infarction, chronic kidney disease, stroke. Best time to treat is to contain the patient when the patient is a person and not a patient. Because if you treat them when they are persons, they will have normal health and normal circulation. So I have given some therapeutic principles in the time that was allocated to me. And Mr. Chairman, ladies and gentlemen, thank you very much for your attention.
Thank you, Professor.